is a series of bi-weekly conversations all about engaging thought leaders, experts, researchers, and healthcare professionals in conversations around the advancement of technology and health sciences. We're happy to have Dr. Kathie Insel with the Arizona College of Nursing with us today to discuss the foundation, development, and evolution of a self-management support system. Please feel free to jump in anytime with questions you have. If you send them in the chat, I'll read them out, but we'll also have some time at the end for questions. And with that, I'll turn the time over to Kathie.
Thank you so much, Caitlin. I appreciate the opportunity to give this presentation. I want to give you a little bit of where my direction was going when I started working on this, and it was really to share with you how you might start off with a behavioral intervention and then have it morph into a need for technology, and I'll explain more of that when we're going through the slides. So I want to say that older Americans, those 65 years of age and older, are a vibrant and growing part of our nation. They also experience some unique challenges to their economic well-being, their health, and their independence. I took many of the slides that I have related to aging stats out of the citation that you see there, 2016 Key Indicators of Well-being. So today, and I'm going to try to do some of this very quickly because I don't want to dwell on any particular part of this, but I want to go over what is the evidence for age-related cognitive decline, and that's important because that is the area around which I've developed the behavioral intervention, and we then moved it into technology. Also, chronic illness and cognitive function, and how chronic illness affects cognitive function. Also, how treatment affects cognitive function. In the case of hypertension, which I'll be focusing on, treatment is critical for preserving cognitive function. And the self-management of chronic illnesses, the association of cognition and self-management, interventions that target cognitive function and hence provide avenues to improve self-management, and then our opportunity to leverage technology to support self-management. So just briefly, an overview of my research, and truly this is not about me specifically, but it's an exemplar of how this evolved and how this came about in relationship to trying to leverage technology. So if you look at my program of research, I'm really focused on cognitive function and how that influences both symptom appraisal and self-management. And then when you look at, well, what goes into that? Over the lifespan, cognitive function, cognitive processes change. So in the kids, we see development of the prefrontal cortex. In older adults, we see some changes that occur in normative aging that influence how people can self-manage medications. We also see influences with chronic disease. So uncontrolled hypertension has a negative effect on self-management. And consequences of treatment with hypertension, treatment improves cognitive function. So people who maintain a healthy blood pressure look no different from those who are normotensive. So to kind of lay the groundwork here, when I talk about cognitive aging, I do not have a negative stereotype of aging. This is not that I think that everyone has dementia when they get over 65. It's rather that there are age-related changes in particular cognitive processes. So there are prefrontal cortical functions that decline with age, and that's the area where online processing occurs in the brain. So it's the active workspace. And there is evidence that implicates changes in executive function and working memory in normal aging. So just to give you a background, if you're not familiar with cognition in these cognitive processes, compared to young counterparts and when followed over time, older adults are less likely to hold and manipulate information. So there's a decrease in capacity. They're less likely to inhibit distracting information. So harder to pay attention, focused and sustained attention, or to be able to switch tasks when needed. So a little bit of a tendency to perseverate. That's one of my faculty years ago said, oh, you mean it's persistence gone bad? And I thought that that's really a good way of putting it because older adults also have learned to be persistent in order to achieve goals. They also may not process information as quickly. And there's more confusion in source memory. Did I do it, or do I think I did it? So did I turn the stove off when I left the house? Did I put the garage door down when I left? Or do I think I did it because I've been doing it every day for the last couple of years or the last several years? You can see how this might be relevant for medication taking, because people take their medications for chronic illnesses like this day after day after day. And it's, did I do it now, or do I think I did it, or do I just think I did it? And there are also declines in prospective memory. Prospective memory is critical for the intervention that we've designed. And that's remembering to perform an intended action, particularly in the face of delays or distractions. So just for your own information, if even a delay as short as 5 seconds in the laboratory can be more difficult to maintain that intention to do the action for older people. So taking medications as intended involves each of these cognitive processes. And you can see with changes in age, once you get to 65, you get some of a decline. Now look at that though, not just the horizontal, but the vertical axis. These are very small changes in capacity. So this is the number of items or working memory span that you can hold in mind. So not to give you too much information, but George Miller back in the 50s identified 7 plus or minus 2. So we could hold, 9 items in mind, or maybe as low as 5 items in mind. But so you can see that we're not talking about a lot of loss here. We're talking about some changes in capacity. This has been, replicated in line span, letter rotation, reading span, computation span, all showing some declines in how much our capacity, working memory capacity, changes. So there are theories of cognitive aging that relate to there may be changes in speed or slowing, working memory declines in attention or declines in inhibition. There are a couple of people there that you might check if that's something that you're interested in. This is important. Declines, we see declines in recall, but not in recognition. Now, why is that important for a clinician like me? Because if you can leave cues, then you see no difference between the way older adults recall and the way younger adults recall. These declines are really in, it's interesting. I see my dean, but she has my name on there. So thanks, Kai, for checking in. So declines in recall, but not recognition, is important in terms of medication taking. Depletion of attentional resources with age and the effects of environmental support also are important for how we design this intervention. So what we tried to do was to transfer processes that are more effortful, the self-initiated processes that decline with age, to associative processes that are more well-preserved with age. So think about that too, because one of the goals of this line of investigation is to decrease burden for people. So managing chronic illness is burdensome, in some cases more so than in others, but in any event, the point is to try to make these things more automatic, less effortful. So I want to focus a little bit of attention on chronic disease and the consequences of treatment on cognitive function. So we know that the percentage of people age 65 and older who report having selected chronic health conditions, this is from 2013 to 2014, but you can see the large number of percentage of people over 65 who state that they have high blood pressure. So hypertension, high blood pressure, it's number one, chronic, costly, and controllable. And I think this controllability is what is so compelling to me, because it is chronic, it has the potential to involve compromises in cerebrovascular flow and cardiovascular systems, and it has deleterious effects on the brain, even without stroke. And it's the number one, reason for stroke, kidneys and heart, as well as, any one of our end organs. The risk for high blood pressure increases with age. We know it's prevalent in people over 65 by 75 years of age, it's approximately 75% of persons over 75 years of age. And the other important piece here is that it's often asymptomatic. So there's no cues, there are no inherent cues to manage this, this chronic illness. So hypertension, as I said, is associated with cognitive decline. This is a cross-section of the brain. You can see the white matter hyperintensities in this brain that are associated with high blood pressure. As I said, increases for risk in stroke, and even in the absence of stroke, increases in white matter hyperintensities. And there's a new article out of JAMA that I just found, and it talks about this national need for a national commitment to improve the care of patients with hypertension in the US. So we also know that medication adherence rates are low, that they're about 50% for people who take medications for chronic conditions. And that clearly results in poor health outcomes because, as I said at the beginning, if you can control high blood pressure, then it's going to be lower. And there are theories of self-management that certainly help us as we think about interventions to include, and they focus on motivation. You know, it's like people just don't want to take them, they just don't know, or maybe they don't realize in terms of education that it's that important, or they don't have sufficient social support, or their relationship with their providers isn't good, so they're not trusting of what they're being told. And there are also belief systems, including self-belief and beliefs about the illness and medications that may influence why or why not medications are taken as prescribed. But they fail to consider cognitive function and the consequent implications for self-management. Even the tested memory strategies that we use, for example, text messaging, may fail to help the older adult recall at the time that they need to recall. So execute and then monitor if a medication was taken as intended. So there are a lot of pieces in this that have to be broken down. So this is a cognitive enhancement model for medication adherence. And I throw this up there just because I want you to know that I'm aware that drug cost, regimen complexity, illnesses, near vision, social support, income, busyness has also been implicated in medication adherence. All of these factors can influence medication adherence. And in our studies, we get information about all of these factors. So taking medication as intended involves prospective memory. And that's what I'm here to convince you of today. And it's dependent on the cognitive processes that occur in the prefrontal cortex. And those processes include executive function, which is the ability to plan, strategize, problem solve, anticipate, focus attention, and monitor. So are you going to get your medications in time for you to have to take them? If you forget to pick them up from the pharmacy, you may not have them even if you remember to take them. So there are a lot of things involved in medication taking. Also working memory capacity that we've talked about. So when you think about taking your medications, you know, the idea is to do it immediately because even a short delay, and delays are filled often with distractions, can avert you from the task that you were intent on doing. I'm going to give you one example of prospective memory failure. So, and I know that you probably all have experienced this. You want to send someone a document, you email them. The whole point of the email was to send them an attachment. You send it and you fail to send the attachment. Sometimes you recognize that immediately. That's sort of like taking medications. You know, people might, oh, I forgot to take that. You know, sometimes you don't. So that's where we've been focused. And the first study that we did was a descriptive study. These are ladies that were involved, they're sisters that were involved in the study, and I appreciated them giving me permission to save their photos. This was the NR03 that I did, looking at whether or not we could predict medication adherence with older adults, 65 years of age and older, and include those measures of executive function, working memory. And what I did was use Betty Glitsky's neuropsych factors. Betty was a professor of mine in the psychology department at the university here. She's still available for me to talk to. Her premise was that there were prefrontal cognitive processes that we could test and measure, and that she differentiated them from medial temporal processes that are more memory-based. We also use the MIMS cap, which are medication event monitoring caps. It has a microchip in the container, in the cap, that allows us to get a count of the medications and when they're taken. So this is the sample. I'm not going to spend a lot of time on this. I just want you to know that these are the sample characteristics. And this is kind of important to my point today, that these, if you look at, a structural equation model of what we were trying to do, we had about 5 measures of executive function. We had a few measures, 4 measures of medial temporal function. And the only predictor, when we included income in the household, dementia, education, illness severity, depression, activity, the only strong predictor was the predictor for executive function on medication taken, and that percentage days correct, number of days taken was the outcome measure of interest. So we did a simultaneous regression, and again, you see that the only one that's really grabbing a lot of variance in the outcome of medication adherence is executive function working memory. So we had something to go on, that this was, an important variable. We also did a small little intervention study just looking at memory strategies and whether or not, you could improve medication taking with using memory strategies, which of course we found happened. So then I was off to designing this prospective memory intervention. And we did this building on the knowledge of prefrontal function. We developed what's called a multifaceted prospective memory intervention to improve medication adherence, the MPMI. It was a 2-group RCT. They were equated. So the control condition included education, same amount of attention, same amount of building a relationship with the provider, the nurse who was in the home. And we also used illness representation concepts, framework, in order to help us identify, people's thoughts about the cause of the hypertension, whether or not they would be able to control it, what the consequences were, timeline if it was a chronic or an acute condition. And this, excuse me, this was funded through NINR. So to give you another view of this, our goal again was to shift reliance from working memory processes that are effortful and that we know decline with age to those that are more cue-driven associative processes, which tend to be more spared with age. So if you look at this, severity of hypertension and age negatively influence working memory and executive function. So the intervention, which then negatively influences self-management. So the intervention was targeted on this relationship between working memory and self-management with the goal of improving blood pressure. So if you think about it, if you try to break down what the components of prospective memory are, they have to do with encoding the intention to begin with, storing it, but retrieving it, importantly, at the right time. It doesn't matter if you retrieve it 12 hours later, you want to retrieve it when you're supposed to take the medication. Execution, because we know that delays as short as 5 seconds are known to lead to failures to perform what you intend to perform. And then that monitoring function that I talked about before, did I do it as I intended or not? So more on the intervention. We developed strategies to address each component of successful prospective memory. The strategies were redundant, and we delivered them in the home with a nurse making use of the situational context. So by what I mean by that is that, where are you? Where will you be when you're taking these medications? If you're in the kitchen, then let's put your medications there. If you're in the bedroom, then let's put your medication there. So we try to create visible cues. And these, if you look at one of the publications, you can find these if you wanted to spend a little bit more time on that. But these were all our intervention strategies. And they included use of implementation intentions. So that's what I was talking about in terms of these action plans. Where will you be? What will you be doing? So our baseline data was collected at the university. We did screen for signs of dementia and severe depression. We had 4 weeks of baseline monitoring. If adherence was less than 90% to the interdose interval, than they were admitted to the 6-month intervention study. And you can see the consort, diagram here with 299 consented, and the number of people who were eligible for the study were 128. That included 63 in the education control and 65 in the education and intervention. So this is just busy. I just want to share that, we did look at whether or not the sample was comparable on age. It was comparable on everything, except obviously those who completed the study at 4 weeks and were not eligible because they were at ceiling basically for medication taking. That adherence was different, 79% for those that had completed 4 weeks, but 61% for those who were admitted into the study. So the results were that the difference from baseline on adherence for the education control condition versus the intervention mean, you can see the difference here, is highly significant. So within the time that we were actually delivering the intervention, we got a huge boost, 35% increase in adherence. But the problem is, and if we looked at it, and I'll show you a diagram, because we looked at it longitudinally, we looked at it from an intra-individual growth perspective. So it didn't precipitously drop when the nurses were out of the home. It just kind of slowly, insidiously led back to where it was. And so what are the implications for that technology? How do you sustain those intervention effects? And you can see this, the dotted line shows you after the RN visits, we had a real boost in non-adherence for people who were non-adherent being adherent. And then that kind of just insidious drop to lower than the control condition, but still higher than where they started. And also just to indicate, and this might not be as interesting, just that people with high executive function in this sample did not really improve with the intervention. The people who improved the most were those who have lower executive function working memory scores. So we know we're getting, the intervention is targeting the tasks that we wanted it to. Then what do we do with that drop? And that's where the tech talk piece of this starts. And that is, how do you sustain, you can't send nurses into a home every week. So how do we sustain it? And we decided, the team decided that we would translate this to a mobile device, an app. And it's called MedsRAM, and it's Medication Education, Decision Support, Reminding, and Monitoring System. And we had a multidisciplinary team. I can tell you that the success of this program is because of the interdisciplinary team that we have. We have experts from pharmacy, human factors and aging, prospective memory, and nursing. And this is an example of some of the people. Unfortunately, not everyone came here, but you can see the folks who were at the kickoff. That's Jeannie Lee, my colleague on the right there, and she is the PI on the new study. Wendy Rogers on the left from the University of Illinois, and she is one of the MPIs for the recently funded study. And our folks at Amphibian, because we needed the computer scientists, to help us translate this intervention to a mobile app, and they've been amazing. So how did we go about doing it? What's the tech part of this? I learned a lot. I learned a lot in the process, and that's why I'm talking about too, is this is a team effort. So I learned about wireframes and looking at wireframes. I learned about coding and how precise coding can be, and how definitive, people want that if-then statement from me, whereas sometimes clinicians are a little bit, if they waited another 2 hours, they could still take the medication. We had to be very clear about how we did these things. We also used structured interviews with about 6 older adults in the community. This was an R21 that helped us with this work. And then we also tested usability. I had tremendous help from within the college, our LHTI group, just setting up a camera so that we could watch people use the smartphone app without having a view of their face, and listen to them so that it would still be de-identified. And they helped me set that up. That was a real gift. And we also had then other people, we had the whole team in another room, and we were telecasting it into the other room so they could watch as the older adult tried to manipulate the screens and what kinds of problems they were running into. And then we did a field test, a small field test, just to see, well, did the app improve medication taking? What we learned is that the oldest old with this particular smartphone intervention, and really we're dealing with cohort effects with aging as well, they had difficulty with vision or touch, and it made it more difficult to use the smartphone. They had no experience with the smartphone necessarily. So those were hurdles for us and things that we learned from this particular study. I also want to give you an indication of some of the user insights from the design. We found with the structured interviews that antihypertensive medication, adherence and perceived knowledge, that people had high intentions to adhere. That's why that motivation, focus in our interventions, didn't necessarily pan out. It's not that older adults didn't want to adhere. It's that they often just forgot. It was just forgetting. They found use of routines helpful. They found addressing misconceptions helpful, and they had a lack of knowledge about hypertension and the medications. They also, and Jeannie Lee, I credit her totally to this ability to create as part of our app a decision support. So if you forget to take your medication in the morning and you're going out the door to spend time with your friends or go to work, and you come back, should you take that medication or not? So Jeannie, along with her colleagues and expertise, created an algorithm for whether or not that particular medication at that dose, given that person's age, it was safe to take the medication when they returned, whatever time that was. So we developed hours, like how many hours, what's the safe window after you've missed a medication for you to take the medication. We also developed the reminding and monitoring piece, but people don't want voice reminders, and they didn't want to have an alarm go off if they were with other people. So they preferred vibrating reminders. They disliked ongoing questions about whether or not medications had been taken as intended. And that can also be a prospective memory problem. So you can have a prospective memory omission where you forget to take the medication, or you can have a prospective memory commission. So you don't remember that you took it because you're having trouble with source monitoring, which is common, and you then take it again. So if you keep on reminding people, there's a concern that you might ask them to be taking too many medications. We had to deal with that. We also had information presentation and utility in terms of the need for accurate, clear, concise medication information. So what we did was we linked the medications that they were taking to websites, vetted websites like National Heart, Lung, and Blood information for lay people on medications, or American Heart Association, things that we knew were vetted and would stay up to date. So we used links for that medication information. And they had some opinions about the app, and I think it's very important when you start to develop an app and technology to take it to the users and find out how they use it. They found the education was helpful, but they viewed the reminders as the most helpful. This is a view of our screenshots, our MedsREM app screenshots. It has now been redesigned, as we're, in another iteration of this, but basically just trying to tell them what MedsREM is. And prospective memory, we know in the lab that people have a tendency to forget to do something if it's time-based, like if you tell them, okay, do this at 8 o'clock versus if you ask them, so what are you doing in the morning when you're taking your medication? Well, I'm eating breakfast or I'm having my coffee. Then link it to those events, linking to an event rather than a time. And then we developed a calendar. So the green is that all the medications that you were supposed to take were taken. The yellow was some were taken, and the red were all missed. The gray were incomplete days. You just haven't gotten there yet. This is an interesting thing because as you work with a multidisciplinary team, one of my colleagues who's been on this from the ground floor, Dan Morrow at the University of Illinois, he thought that then it was okay to take a percentage of medication and not all of the medication. So, you know, as he was working on the visualization team right now, as we've got the MedsREM2 iteration going, he thought he could use color coding to say, okay, green is when you took 75 to 100% of your medications, or, you know, yellow is when you took 25 to 50. And, you know, Jeannie and I are looking at him as clinicians saying, it's not okay to miss your medications. You know, where's the evidence for it being okay to not take all of your medications that's prescribed? So it's very helpful to have every member of the team, I can tell you that. So just to give you a little bit of summary on the field test and what that looked like, the results looked like, we did see an improvement. You know, this was a within subject design, so we looked at them for 4 weeks. They measured their adherence. We did the intervention, then measured their adherence for 4 weeks after. We did the intervention means that we gave them the smartphone and had them work with it. And you'll see the improvement here in adherence and the p-value for those. But this is really the most interesting finding. It was just a t-test for within subject, baseline adherence, and follow-up adherence for the 9 that we had full information on, was that this was a significant difference and significant improvement. And this was just a small little field test. So we didn't do an efficacy trial, which is what we're also trying to do in this next iteration. And they said that the reasons for dropping out would be that they got too frustrated with the smartphone, or they didn't want to set a regular time to take the medication because she was too busy each day to create a schedule she could adhere to. So mind you, we're not trying to impose a routine or a schedule on people. We're trying to go from where they want to be. What is your schedule? If you wake up at 10 every morning, that's fine with me. You know, let's design it around that. But she didn't want a routine at all. So that was her reason for dropping out. So the exit interviews from the field test indicated that they overall liked the appearance, the graphics, and the color. They liked the reminding schedule function, the best part. They least liked, we had some slow load times between some screens. We're trying to correct that. The undo prompt on the medication entry screen didn't really exist. Now we are putting in a back button. The reminder tones were sometimes too quiet, and we didn't have an Android version. But you know, we're confident that if we are designing this for an iPhone, that we can translate it to Android at some point down the road. Also, it's very important in the self-management literature to give people feedback on the clinical parameter that you're looking at. So in blood sugar monitoring, for example, it's having the ability to monitor your blood sugar while you're trying to engage in lifestyle changes, while you're taking your medications, you know, is good. It's helpful, at least the literature would indicate, in terms of sustaining the medication taking. So we would like to link this to our blood pressure cuff, which is what we're doing in this iteration as well. So the challenges that I found in translating a behavioral intervention to an app: reminders, translating a time-based task to an event-based task, and tailoring that notification for people. But we accomplished this. We also accomplished the monitoring. Did I do it, or do I think I just did it? Because they have to discharge the reminder on the phone. And then decision support. The decision supports algorithms that Jeannie developed for the first iteration were on 10 of the most commonly taken blood pressure medicines. So, and feedback, the calendar showing adherence, I think, was helpful. We were able to accomplish that in terms of the translation, and linking to these vetted sites, I think, was easy for us to do. What I think was missing, you know, provider relationships with providers really does is important for people. So we are trying to develop the relationship with the app as the coach. And then we also would like to connect to EHRs, so that they could just be downloaded in the provider's office or in the hospital. This is the information. This is the way my blood pressure's been going. And feedback about progress with the clinical marker of blood pressure. And also what I've learned from the computer people is that if you get optical image capture, you know how some of these medications, their generic names are just so long, and that trying to get people to enter a generic name, we just wanted to avoid that totally. So trying to get a picture that would then be captured and would automatically upload with that medication for an older adult. So that next iteration has been funded. The co-PIs are Jeannie Lee from College of Pharmacy and Wendy Rogers from the University of Illinois. I remain involved as a co-I on the study. We're expanding the usability to do the partnering, the education, the coaching, to include the optical image capture and to link to a clinical outcome of blood pressure measures. I want to acknowledge that it takes a team to do any of this work. I benefit from the expertise of so many other people: Gil Einstein, Dan Morrow, Jeannie Lee, Wendy Rogers, Tracy Mitzner, Kenneth Blocker, from a student from Georgia Tech, and the team at Amphibian, and my own personal mentors and cheerleaders. I just want to say Lee Seacrest, Carolyn Murdow, Carrie Jo Braden, and Betty Klitsky. Thank you. So questions. Whoops, maybe I should have left that one on. Caitlin.
We did get one in advance, which I emailed to you, but I'll read it again. It's from Chuck Palm with Banner. He says, we work with diabetes patients who have issues related to medication adherence, self-management, and behavioral change. Have you seen texting to be an effective method for connecting with patients to help them?
Yes, and I think one of the things that the literature shows that texting does benefit people. One of the nice things about texting is that it can be done at the time, the target time. But then what do you do if something happens in somebody's life and they can't do it when the text message appears? So it still is not a complete answer in terms of prospective memory and prospective memory failures. But I also think that text messaging can function as a coach. You need a cheerleader on the side. You need someone who's saying, oh, you did this, or here's what you need to do, or, positive, uplifting messages that keep people engaged. And text messages, even though they're virtual, I believe that you can design them such that people feel like they have the relationship that you're trying to create with them in order to improve their adherence. So yes, I think text messaging is great. I don't know that it's sufficient as a system.
Awesome. We don't have any other questions in the chat, so if anybody wants to just jump in with questions, please feel free.
I have a question, Katie.
Yeah.
Yeah.
Yeah, Ted.
You're working with a population of elderly people, and we worry about hypertension in people who are 30 years old, 40 years old. Is there anything applicable from what you've learned here to say, let's push it up earlier, because we want the people to be better controlled with their blood pressure so they wouldn't get to 65 and are, stroke risks?
I agree with you. And I think that what works for people who are 65 years and older will also work for people who are younger. One of the issues for the more middle group, I don't want to say middle-aged because 30-year-olds are not middle-aged. And certainly we see people who are 30 with high blood pressure and even younger, unfortunately. But it's often that they're busy, that they're distracted. So you can see the benefit of having something that would bring this to their attention. Oh, yes, I need to do this now. And also all of the things that we're building in, medication education, decision support, reminding and monitoring that they actually did it, those things will support younger people as well as older people. So to the extent that we can improve this app, I think that it has generalizability to other populations. The other thing we've looked at is that there are populations like women with breast cancer who have undergone chemotherapy and the ideas of chemo brain. You know, there are other populations that have trouble with a chronic illness that is asymptomatic, like hypertension is. So what cues them, what reminds them to take these medications? So I think that there's a value that we could test this. That would be the next, you know, generalizability question for our external validity. Can this also help people in younger age groups? I think it has the potential of doing that.
Thank you.
Thank you. Anything else? And Ted, thank you so much for that question. I really appreciate it.
I just have a comment rather than a question. I think your discussion on being able to generalize this and make it more applicable to different groups is really interesting. Personally, I have multiple sclerosis, and I know for a fact I skip my medication far more than I should because I'm busy, because I forget. And, you know, they'll send you little text message reminders or things, but if I get it and I push it, oh, I'll do it in 5 minutes. Well, 5 minutes later, you forget. So I think it's really interesting the potential this project has to become something that completely revolutionizes the way people who take medication consistently in general take it.
Caitlin, thank you for that. And I agree, you know, we lead busy lives, you know, so I think it does have potential, and I appreciate your personal example. Thank you.
Does anybody else have any questions before we wrap up today? It looks like we're good. Kathie, thank you so much for doing this presentation. It was so interesting. And for everybody that attended, we will have this posted on the Health Sciences YouTube channel, hopefully by the end of this week.
Thank you, Caitlin, and thanks everyone for your attention. I appreciate it.
Thank you.
Ted, talk to you later.